Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Hi David, how are you doing?
Good, thank you. Ready for some more clotting action?
Fantastic. So today we are going to do all about investigating the prolonged clotting screen. So we've talked about when we do a clotting screen, when we don't do a clotting screen, and how the APTT and the PT basically work. And now today we're going to talk a bit more about how we then approach that abnormal clotting result and where we go with that test from a practical hemostasis point of view, really. So I thought the best place... Oh, and just to say for people listening at home, what we will cover today are mixing studies, and we're going to do all about factor assays. So both the 1-stage, the 2-stage clotting assay, and the chromogenic assay. And we're also going to talk a little bit about the pros and cons of those different factor assays and discrepancies between them. What we are not going to cover today is things like the thrombin time and all their related tests. We're not going to do the inhibitor assays today, because that should just be a whole separate podcast on its own. And we're not going to do anything about going into detail about the lupus screen either. So that will also be another podcast along the line.
I think that's sensible, or you would be here all day.
Yes, exactly, which I would be happy to do. Would you, David?
No. I've got about a 30 to 45 minute attention span, so yes.
Okay, fine. All right, so let's start with a case. These are all made up cases, as a disclaimer. The numbers are not necessarily true, but I've just picked numbers that are outside the reference range that vaguely illustrate my point. Okay, so I am a haematology registrar on call, and I get phoned about a 13-year-old in A&E who has come in with signs of infection and needs an operation for query appendicitis. And the APTT comes back at 60 seconds. I'll give you a reference range, so between 27 and 35 seconds is normal.
It felt long. Yeah. I've never heard it described in a minute. Yeah.
Yeah, that's true. So what are you going to do? Talk me through what you're thinking here.
Okay, so I'm going to reference back to what we discussed previously and realise the best thing you can do is a really good clotting history.
Lovely.
So, yes, we'll use our HemeStop acronym.
Yes,
I guess the challenge with this sort of scenario is they're quite young.
Mm-hmm.
I know I've noticed you've sneakily not told us what gender they are as well.
Yes, is that relevant?
I think it's relevant. Yeah,
why is that relevant?
Specifically for X-linked genetic problems with regards to factor deficiencies.
Very good. So
and I guess because they're so
boy.
Yeah, and I guess with regards to the HemeStop thing, it talks a lot about previous things, doesn't it? So sort of hematomas or tooth extractions or surgery, obstetric problems. That's unlikely to pop up in a young patient.
Yeah.
So we might be looking at parents as a question.
Yeah. That's a very good point, David. Because you're right. All of these, the bleeding history, I'm not knocking it at all. As you know, it's very important, but be aware of the limitations of it, particularly when doing some of these questionnaires like the HemeStop questionnaire that we were talking about last time. It's not been validated in studies as being sort of effective at picking up a bleeding disorder. And probably part of that is because, as you say, the whole basis of a bleeding history is assessing a person's response to previous hemostatic challenges. And if you're 1 year old or 12 years old, you've not had an opportunity to have very many hemostatic challenges. And this imminent surgery for this 13-year-old boy might be his first hemostatic challenge. So that's not very helpful to you. Yeah, that's a really good point. What other aspects of the history would be helpful to you, perhaps?
So I guess the bruising side, if they'd noticed that they'd had bruising from, I don't know, boys do things that are silly, they play football and get jump off things. I guess
Okay.
also
Yeah.
we talked about the difference between sort of oozy bleeds and sort of deep-seated bleeds. I
Okay.
suppose that's a sort of a question I'd like to ask and get an answer from.
Yeah, that's a good
Um,
point. Like a severe haemophilia A, you would probably expect a joint bleed or something by the time they've got to the age of 13. Because normally those sorts of things present when they start becoming mobile. So,
yeah.
around the age of 1. Another thing to think about is also things like bleeding from the umbilical stump as a baby, or bleeding from or a hematoma formation from the Vit K injection that babies get when they're born, or from the heel prick potentially. But yeah, so sometimes you can draw out a bit more, but a lot of the time it's not there in the history. But other things you can ask about are family history, not always reliable, but can be, and drug history as well. So that's going to be important. Okay, cool. So, but then what are you going to do after that? So, there's nothing in the history. Let's just say there's nothing there to speak of. But you've got this abnormal APTT, and you're not sure what to do next.
So this is when I'm going to get slightly out of my depth.
Okay.
um, I'm decent for one Y deep, but two Ys deep, maybe not. I
What's the base? Okay, let's go through the causes again of a
yeah.
prolonged APTT. So,
So I'm concerned if it's an isolated prolonged APTT that
okay,
this is
good.
an
Stop there.
yeah.
So, isolated APTT. So, I haven't given you the PT, have I?
No.
Yeah.
Smart. You've done this
So,
before.
the PT is normal. So, yes, carry on. We're
Okay.
going down the
So
isolated APTT.
so I think this is an intrinsic problem. So I'm
Okay.
thinking factors 8, 9, so hemophilia A and B, and
Hmm.
then 11 and 12.
Very good.
If Yep,
Yep.
he looks for confirmation.
Yeah.
I'm wondering if there is a problem A with those factors, or is there some kind of antibody or anticoagulant going on here?
Okay, very good. So, yeah, an antibody could be a lupus anticoagulant, like we were talking about before, or it could be an acquired haemophilia A, where you get an autoantibody against your factor VIII, or it could be a haemophilia A or a haemophilia B, and it could be certain types of von Willebrand disease as well, which can drop your factor VIII, for example. So, yeah, so the broad concept of what you're telling me there is it could either be due to not enough factor, so a factor deficiency, or it could be due to something that's inhibiting your clotting screen, your APTT, be that an antibody or be that a drug. Okay, so good. That's the general concept. So then, how might we tackle this, and the way in which we can kind of try and understand which one it might be, which will allow us to go down the next correct route, is using a mixing study. And you might have seen them come up on a blood test result because the lab will often do them as part of their kind of SOP. So with a mixing study, it's as simple as it sounds. And the standard mixing study that most labs will do first line is a 50-50, where you basically take the patient's plasma and you mix it with normal reference plasma in the lab at a ratio of 1 to 1. And given that the PT and the APTT are both designed such that you need more than a 50% drop in your factor level before your APTT or PT are prolonged, it means that if you add 50% normal plasma, then if there is a deficiency in a factor, it will correct the APTT or PT back to the normal range because you've provided 50% factor by doing a 50% mix. Does that make sense?
Yes, suddenly the whole 50% drop thing makes sense, and yeah, requiring 50% for it actually to register as an anomalous result. So yeah, it's almost
Yeah.
like someone planned it.
So yeah, so basically then, there are other mixing studies that you can do. So you can do a 4 to 1 ratio where you do 4 parts patient plasma with 1 part normal plasma. And the benefit of that is that it prevents sort of flooding of a weak inhibitor. So if you had a lupus anticoagulant antibody that's quite weak, if you just dump 50%, of the solution now becomes normal plasma, so you dump a whole load of factor VIII in from that normal test plasma, then it can just completely neutralize the antibody so that you don't detect it anymore, and therefore it corrects, and it makes you think therefore that it corrects due to a factor deficiency, but actually it was just a weak inhibitor that you flooded. So if you do
Okay.
suspect that this is a lupus patient and then the mixing study corrects, you can then say, okay, well, actually, let's just do a 4-to-1 and just check that it's not that we're just, flooding and neutralizing an antibody, a lupus anticoagulant after all. Does that make sense?
Yes, that feels very chat to the hemorrhage kind of conversation.
Okay, fair enough. Um, and just one other thing to say, particularly for haematology registrars looking at exams, often the term failing to correct means that it has to go back to the normal range. If it doesn't go back to the normal range, even if the number improves, that's kind of caught me out before when doing practice questions. So, you can have an APTT that does get shorter with mixing, but if it's not in the normal range, then we would still say that that's a failure to correct.
That's one to stash away.
Yeah, and that makes sense because of
Mm,
the fact that the tests are calibrated such that you only really need 50% of normal factor levels to have a normal PT and APTT.
cool.
The other thing to say is that when you do a mixing study, you should then run the APTT both immediately and then after incubation. And that's important because different inhibitors can act at different times. So some antibodies can bind straight away and then affect the clotting result. Other antibodies take a little while to bind and to have an effect. So therefore, it's whenever the lab will do a mixing study, will report it as an immediate result, and then on incubation. Incubation is usually for 2 hours at 37 degrees. And that will then allow you to compare your degree of correction both immediately and then also on incubation. And it will allow you to work out the likely type of inhibitor that you've got.
Is that kind of thing clinically significant? In this case, he's going to surgery, or is this more a sort of thing that hematologists like to know because they would be able to treat it in different
Well, no, I
directions?
mean it is important in getting to the bottom of what's causing the problem, because, for example, your factor 9 inhibitors that patients with haemophilia B can develop. So this is where you've got haemophilia B, you're given Benefix, which is replacement factor 9. And then you develop an allo antibody against that factor that you were given because your body hasn't really seen much factor 9 before. And so it sees it as foreign and you develop an antibody. And those antibodies, those inhibitors in haemophilia B, act immediately. And that also correlates with the fact that they are at risk of anaphylaxis for their first doses of having factor 9 replacement in haemophilia B. And so you would see in that sort of mixing study that the patient's APTT would fail to correct both immediately and on incubation. If you just did an immediate mix and you didn't do the incubation, then you're going to miss antibodies against factor 8, which typically need more time. So a factor 8 deficient patient, so a patient with haemophilia A who is given factor 8 replacement and then develops an alloantibody against the factor 8, that antibody acts more slowly. It doesn't have any effect in terms of neutralizing the factor in either A or B. It both means that the factor isn't really going to work and that they're at risk of bleeding, but they don't get the anaphylaxis risk in the same way. And basically, I guess what I'm trying to say is that if you don't do an incubation, you might miss an inhibitor against factor 8. So that's the risk.
That's really helpful to know. Yeah.
Yeah, yeah. No, it's a really good question. So let's try and apply these concepts rather than it being a lot of me just kind of dragging on. So, okay, we've got a prolonged APTT and I do a 50-50 mix and it corrects. What does that tell you? Just
So that suggests to me there's a clotting factor deficiency.
very good. So in that situation, I would go on to then do my factor assays for the factors that you were talking about earlier. So I'd do 8, 9, I'd do 11 and 12. Good. What if I had a 50-50 mix and it corrected, but then when I incubated it, it then failed to correct? So initially I was like, oh, it looks like a factor deficiency, but then after 2 hours, it then failed to correct. What would that be?
Is that like an acquired antibody or just an
Yeah,
antibody?
it's a factor inhibitor, and it's probably a
Yeah,
factor inhibitor to factor eight. Yeah,
yeah.
very good. Okay, what if I did a 50-50 mix and the APTT failed to correct both immediately and on incubation?
Um, so there's no correction.
No
That
correction.
suggests so there's an inhibitor present.
Yes, yeah. And that inhibitor could be like hemophilia B inhibitor against factor 9 that's immediately acting, or it could be a lupus anticoagulant.
Yeah.
And then, of course, the other thing to just say is in a less predictable way, if you have any drug around, like unfractionated heparin or one of the DOACs, then that also will fail to correct potentially, depending on how high the drug level is, both
Yeah.
on immediately and on incubation. Does that make sense?
Got you. Yes. No. No. Good.
Awesome. Okay, great. Because sometimes that I worry that that's quite hard to explain to people, and it's actually a really helpful concept. And if you understand that really well, you then know where you're going. Are we talking deficiency, or are we talking some sort of inhibitor?
Yeah. I think when you get your head around what the test is testing for, and
Hmm.
you can kind of work it out each time.
Yeah.
So, trying to remember those numbers, very hard.
Yes.
Working it out each time,
Yeah.
very easy.
Yeah.
So,
Exactly. Okay. Brilliant. There are some labs. I have never seen this being done, but you can, instead of using normal plasma, when you do your mixing, you can mix the patient plasma with plasma that's been fiddled with. So reference plasma that's been absorbed, for example, to remove your vitamin K dependent factors, just to help you isolate further if it does look like there's a deficiency in a factor, which factor it might be.
mhm.
But in all honesty, I think that is more of academic interest, because if it looks like it's a factor deficiency, you're just going to go on and assay your factors, which
Yeah.
leads us nicely on to factor assays. So, um, do you know the general principle behind how we assay factor levels?
No. No. I've got some ideas in my head,
That's
which
fine.
involve
I
sort
wouldn't
of like
expect you to.
antibodies that are flagged with fluorochromes and things, but actually I would just be spitting stuff out.
That's fair enough. So let me explain the general concept of factor assays first then. So you've got three different kinds: your one stage, your two stage, and your chromogenic assay. We generally labs start with a one stage clotting assay because it's quick and easy, and it's I find it the easiest to understand as well. So the whole concept of a one stage clotting assay is that we take factor deficient plasma in the factor that we want to assay. So for now on, we're going to just pretend that we're talking about a potential patient with haemophilia A. So we want to assay the level of factor 8. So to do that, we take factor that's made in the lab that's specifically had factor 8 removed from it, so it's factor deficient plasma, which we define as less than 1% factor 8 activity within the plasma. And then we use our patient's plasma to try and correct that factor deficient plasma. So we take our plasma that's specifically deficient in the factor that you want to test, so factor 8 deficient. We then take the patient's plasma and we mix it together. And then we compare, well, we then measure the clotting time, which for the sake of a factor 8, it's obviously going to be an APTT because we're measuring that's the factor that's in the intrinsic pathway. If it was factor 7, we'd be doing a PT based assay, for example. But for factor 8, it's an APTT that we then measure, and then we get a number at the end, time, and we then compare that with a reference plasma with a known amount of factor 8 in it. And we therefore compare how well or poorly your patient's plasma has been able to correct that APTT. Does that make sense?
So is it quantitative based on time?
It's based on time, yes. And yes, it is eventually quantitative because we have a time that we have a graph of
Yeah.
what we know the reference plasma with the known amount of factor in takes, like what the APTTs are for a known amount of factor 8. And so in the end, we convert it. So something that might be useful is to get up the page on Practical Hemostasis website, for factor assays, for the one-stage factor assay, because there's a graph on there and a worked case that we can sort of talk about as well, because it's otherwise can be quite difficult to visualize. But essentially, you've got your factor deficient plasma, of which your APTT is very prolonged, and then you're mixing in your patient's plasma, which should shorten the APTT significantly and actually normalize it if it's a 50-50 mix and your patient's got completely normal levels of factor VIII. Does that make sense?
Yeah.
But if you've got someone with the reduced factor VIII levels, it's not going to correct that APTT to normal. And the degree in which it corrects is how we work out how much factor that patient's plasma has in it.
Yeah.
So the actual method is we take the patient's plasma and we do a set of serial dilutions, at least 3, so that we can then plot them on a graph. And we take the patient's test plasma with an unknown amount of factor in, and then we also do the same set of serial dilutions for a reference plasma from the lab where we've got a known amount of factor in it. We mix each serial dilution with the factor deficient plasma and we incubate it. And then we measure the APTT. And then we plot both lines on a graph in which the y-axis is the clotting time, so the APTT in this case, and the x-axis is the dilutions. And the 2 lines on the graph are the test samples and the reference plasma samples. And usually when you look at that graph, the test plasma line will be higher than the reference plasma line if you are looking at a patient who is truly deficient in factor VIII, for example, because all of their APTTs for all those different serial dilutions for the patient's test plasma are going to be longer than the reference plasma line, where you've got a normal amount of factor, which will therefore correct the APTT better. And then using that graph, you then go up at 1 in 10, which is taken as 100%. So you go up at that dilution on the x-axis until you cross your patient's test plasma line. And then you extrapolate across horizontally, which is looking to therefore see what your patient's test plasma is equivalent to in the reference plasma, which in this example is it crosses and then you go down and it's at 2.3% compared to the 100% for the reference plasma. And then basically you then just need to know how much factor VIII activity was in your reference plasma, which in their case was 95 international units per DL. And so you then just need to work out the percentage of that, so 2.3% of the 95, which gives you an answer of 2.2 international units per DL. So that is then consistent with a patient who is deficient in factor VIII. Does that make sense?
Yeah. For those who are driving, don't look at the screen. Don't look this up on there. But if you're at home, the practical hemostasis website, really great, and it makes sense when you can look at it.
Yeah. So we suggest you listen to that bit again, having a look at the graph, definitely. Good. Okay. But that makes sense to you, David, looking at the graph?
Yeah, no, absolutely.
Okay,
I can see it from here. It makes complete sense, especially because it's logarithmic along the x-axis. So
yes,
it's useful, to get your head around those things.
Yeah. Brilliant. And then the other thing just to mention is that let's say we're not in a scenario where we had a prolonged APTT that we were investigating, but instead we had a patient with a known haemophilia A who was coming for an operation in a couple of weeks' time electively, and we wanted to do factor VIII levels to make sure that we know what their baseline is, to calculate how much factor replacement they might need, for example. The machine, well, this is all automated, but let's say we did it manually and we plotted it on graph paper like this. Something that we must always check, which is why we always need to do at least 3 dilutions, is for something called non-parallelism, which is basically where those 2 lines, the test plasma line and the reference plasma line, they need to be parallel to each other. So they need less than 20% deviation between the 2 lines. And do you know why that might be important, David? What might affect the lines not being parallel?
Well, this is the first time I've seen this graph in my life, so I'm going to say no.
Okay, fair enough. I'll stop asking these questions. Sorry. So
being bullied, the academic punch bag. It's fine. I've got it.
I'm sorry. So it's called non-parallelism. It's really important that we look for that. And the reason why is because, okay, firstly, your lines could not be parallel if you just haven't run the test properly or if you've plotted the data incorrectly. But the big reason is because if there's an inhibitor, then the serial dilutions will usually affect the inhibitor more than the patient's factor. So your line therefore becomes not straight as you increase your degree of dilutions. Does that make sense? Until you
Yeah, no,
eventually lose the
absolutely.
effect of the antibody altogether as you dilute it out.
Yeah.
And so what the machines do when they're automated, so going back to this patient that's got elective surgery coming up and they have their factor 8 level run and then the machine detects that the lines aren't parallel, that will then flag and say, whoa, this is non-parallelism. And it basically will then signify that you need to go on and do an inhibitor test, a Bethesda assay, which we'll talk about another time. But it's very useful because otherwise you might not know the patient's got an inhibitor and that could be disastrous. So that's why you have to do at least 3 dilutions to make those straight lines and to plot both of them if you were doing it manually, which is what the machines do. And then I guess the other thing to say is that if you had somebody with really very little factor, then sometimes that can also cause non-parallelism because if they've just got so little factor, then you can't dilute nothing. So again, the lines may then not be so parallel.
Yeah, it
So
would just be flat.
yes. Good. So that's the one stage plotting assay. Maybe I should just mention something about units at this point. So we've been talking about international units per DL, and I like those units because I can think about it in terms of a percentage. So one international unit per DL is 1% basically in my head. So therefore, if someone had a factor 8 level of 50 international units per DL, I think of that as like, okay, so they've got about 50% factor. And if they've got 100 international units per DL, which is what you might aim for a big operation, then that's 100%. So I quite like those units, but we are actually encouraged to use the international units per ml. So the conversion of that would be 0.01 international units per ml is equivalent to 1 international unit per DL. So yeah, that's just a note on units because otherwise you
Yeah,
can get yourself
easy to get caught
confused.
out on that.
Yeah, exactly. And I think different hospitals use different units. Okay, so let's move on to the two-stage clotting assay then. So the two-stage clotting assay is then what you would then move on to do because, well, we'll come to it later, but you want to, if you do your one-stage assay to start off with, you then do want to go on to do either a two-stage clotting assay or a chromogenic assay to confirm what you found. So with the one stage assay, there's just one stage to determining how much factor 8, for example, there is by measuring the APTT. And then, it's a standard APTT and you're measuring a clot formation as your endpoint. But in a two-stage clotting assay, there are 2 stages, clues in the name. And the first stage is that you make factor 8 the rate limiting step in producing 10A. So that's the first stage. And then the second stage, instead of just running an APTT and measuring a clot, once you've incubated this mixture to make 10A the as much 10A as possible, which is dependent on your amount of factor 8, then the second stage is then assaying the amount of 10A that's made rather than just allowing it to run to make a clot. And you can assay that by, well, in a two-stage assay, you will then run it to make a clot as a second step. But in a chromogenic assay, which has largely replaced the two-stage assay, you then add a chromogenic substrate, which can then be cleaved by 10A and cause a colour change, which you can then detect. Does that make sense?
Yes. How are we presenting? How are we preventing the 10A going on to make a clot?
Yeah, that's a good question. So we basically deplete the plasma so we take the patient's plasma and we adsorb it so that we remove factors
Oh, the
2.
down the downstream common pathway
Yes,
bits. Okay,
exactly. Yeah.
cool.
So it's therefore frozen at 10A
Yeah.
and it can't go on until we then take that sample and add it to normal plasma. And then at that point, it's allowed to clot in the two-stage
Okay.
assay.
Unless we do the chromogenic. Oh,
unless you do the chromogenic one. So
okay.
just to talk through the method step by step of a two-stage assay, you take your patient's plasma and you adsorb out your extrinsic pathway clotting factors. So you've removed your 2, your 7, your 9, and your 10. And you do take out your extrinsic pathway clotting factors, but adsorbing it is removing your vitamin K dependent factors. And then you mix that with your factor 5, your phospholipid, and your calcium, and you basically generate this sample that factor 8 is the rate limiting step in generation of factor 10A. And so your factor 8 binds with your 9 when your factor 8 is activated, and then makes the 10A's complex and makes factor 10 active. Yeah. And so you have to incubate that for a while just to give it as much time as it might need for all of the factor 10 that's going to be converted by factor 8 to be converted into factor 10A. And then the second stage is then taking all of that mixture and adding it to normal plasma to allow a source of particularly 2 to then allow the clot to form. And then you measure that time that's taken for the clot to form once you've added your mixture into the normal plasma. Does that make sense?
Yes. Yeah.
Sorry,
It's
I
a
keep
little bit more
asking you that.
complicated than the first one, isn't it?
It is a bit more complicated, and I think I wouldn't get too bogged down in the detail of the two-stage clotting assay, mainly because it's been made slightly redundant by the chromogenic assay. But basically, it's just more about what I would like you to be able to take away is the general understanding of it, which is that your first stage is you have a setup, which don't get too bogged down in the details, but you have a setup which basically makes factor 8 the rate limiting step in producing
Yeah.
active 10. And then you have your second step, which is your 10 then being the thing that determines how quickly you clot.
Okay. And is
And
this only specific to factor 8, or are there sort of equivalents
that's
for
a good
other
question. That's a good
intrinsic?
question. So they're
Okay.
only this two-stage clotting assay is only available for 8 and 9.
Okay.
So good question. But we don't really do this one so much anymore because nowadays the labs buy these kits called chromogenic assays. And chromogenic assays are essentially the same concept. You've got the first stage being incubation step to generate 10A, dependent on how much factor 8 you have. And then the second stage, which is determining how much 10A is made to extrapolate how much factor 8 you've got from that. But instead of
Yeah.
letting it clot this time, you add a chromogenic substrate.
So you can tell by how much, how yellow it is, how much 10A
Yes,
there is, and therefore you
yes,
can extrapolate backwards how much
yes,
8
yes,
there is. Okay.
exactly. And so your factor 8 levels can be calculated from the absorbance of the sample at a specific wavelength.
Yeah.
And
Which is the smart version of how yellow it is.
yes, exactly. Yeah,
Yeah.
exactly. And just to say with the chromogenic assay, I think this one is worth just making sure you understand what goes in that kit that you have. So what you have in the kit is active 9, okay, because we don't want factor 9 to be limiting in any way. So factor 9 is active in the kit, so it's in excess. Factor 10, which is not active, because that's what's going to be made active by the patient's factor 8 level. And thrombin, i.e., active 2A. And I guess the thing that I got stuck on with this is not understanding that thrombin activates factor 8. Okay.
Yeah.
And do you remember we talked about that in the whole thrombin burst propagation stage of clotting when we
Yeah.
said about how the clotting cascade isn't 2 parallel pathways
No, it's quite
common.
cyclical and
Exactly.
exponential.
And so
Yeah.
you get your extrinsic pathway usually makes your initial bit of thrombin, and then your
Mm.
thrombin feeds back and activates lots of other things in the intrinsic pathway as well, and that makes your amplification of the clotting cascade. And so
Yeah.
that's what this chromogenic assay is kind of building on. So you've got your factor 9A that's active, so that's not limiting how much factor 10A is made. You've got your factor 10, which is not active, that's your substrate basically. And then you've got your thrombin, your factor 2A, which is active. And then you add in your patient sample, which contains an unknown amount of factor 8. And that unknown amount of factor 8 gets activated by thrombin into activated factor 8, which can then bind to the active factor 9 that's already in the kit and can make the 10A's complex and activate factor 10 into 10A. And obviously the kit contains calcium and phospholipid to allow that to occur.
Yeah, that makes sense. So
Yeah.
it sets up the best case scenario for
Yes.
factor eight to do its business,
Yeah.
and therefore you
Brilliant.
can measure it a little bit. Yeah,
Yes.
if it's
Exactly.
there, it'll be measured.
Exactly. And so that's your first step. And then once you've let that incubate, which I think they normally incubate them for like sort of 10 to 15 minutes. And we'll come back to this incubation thing because this is relevant. But they incubate for about 10 to 15 minutes. And then you add your chromogenic substrate, which changes color. And then you measure that. And then from that, you can then use a reference curve, which again, I would refer to the Brilliant Practical Hemostasis website. But they basically have a reference curve of absorption against a known concentration of factor VIII. And so you can then just extrapolate quite simply off that curve to know how much factor VIII the patient has.
Right.
So you might then ask, well, why do we bother with the one stage assay? And why do we why have we got 3 different assays that are all doing essentially the same thing? And that's a good question. I've said that the one stage clotting assay is quick. There's no incubation time really needed. It's just basically an APTT and it's cheap and it's easy. So it's a good screen. But the problem with the one stage clotting assay is that it can miss up to 10% of mild haemophilia A patients in particular, because it can, in those patients, overestimate how much factor VIII they have. So if you get a borderline result or your result doesn't fit with the bleeding history, then you should definitely go on to do what's normally then a chromogenic assay. The chromogenic assay is also less susceptible to interference from things like a lupus anticoagulant or heparin or low molecular weight heparin, because you can work with quite a dilute solution of patient's plasma. And the other thing is that this degree of colour change by the chromogenic substrate being changed by 10A, it permits quite a high resolution of knowing how much factor VIII you've got. So it's quite useful for particularly patients with very high or very low factor levels. So that's another benefit of the chromogenic assay. And then another thing is something that we will talk about later, but there's this amazing drug called emicizumab. I don't know if you've heard of it.
No.
Okay, well, it's basically a very cool antibody that a lot of haemophilia patients are now on, and it's subcut injection every 2 weeks, and it basically cross-links 10 and 9, and therefore kind of rebuilds the 10A's complex without needing actual factor VIII. So it bypasses the need for factor VIII, and it's very cool because it renders patients essentially with severe haemophilia to now have more of a mild haemophilia phenotype. We'll talk about that in a haemophilia podcast, but it's very cool. And
It's a little taster, a
yeah,
snippet of what's
exactly.
to come.
But emicizumab basically will short circuit the APTT because of what it does. And so you'll get very shortened APTTs on emicizumab. But that can be a problem if you've got a patient on emicizumab who needs an operation, because you still want to know what their underlying factor VIII levels are, to know, whether they might need some factor support as well, or if they bleed, for example. And obviously, you can't do that with any of the assays because of the cross-linking effect of the emicizumab. But you can buy a chromogenic assay kit where the factor 10 substrate that they use in the kit is bovine instead of human. And the emicizumab antibody can't bind the factor 10 that's from a cow. And so therefore it allows you to do an assay of the patient's underlying factor VIII levels when they're on emicizumab, which is quite cool.
Yeah, feels a very consultant-only lab test.
Yes, it definitely is. And I'm not even sure if we do them in Derriford or whether we send them to Bristol. But they are available. So and then finally, let's just talk about why the one-stage clotting assay can basically miss some mild haemophilia A. And we call this discrepancies between the two tests. And you've got 2 kinds of discrepancies. You've got just discrepancy, and then you've also got a reverse discrepancy. So discrepancy is where you've got your factor VIII level comes up higher in your one-stage clotting assay than it does in your 2-stage. And this is specifically due to mutations that some patients may have in their factor VIII. I think it's usually in the A subunits of factor VIII structure, which basically affects its ability to bind for a prolonged period to factor IX within the 10A's complex. So initially it will bind and produce a decent factor VIII result on the one-stage clotting assay because it binds and produces a decent correction of the APTT, right? But in the chromogenic assay, where you've got an incubation period, it will bind, but then it will fall off again. And so then by the time you measure the amount of 10A that's been made, it's less than you would expect because you've got initial 10A's activity and then initial factor VIII activity, and then it will drop off and you won't get as much factor VIII activity. So not all of the 10A, not all of the 10 will be converted into 10A compared to what you would expect. And
At which point, I suppose you're doing something genetic, or would you actually just go, actually, this is enough clinically
the
speaking to
discrepancy.
diagnose?
Well, it more just highlights why we do a chromogenic assay as well.
Okay.
Because we would have missed that patient if we'd just done a one-stage clotting assay. And actually, it's clinically relevant if their factor VIII binds and then drops off and that they can't make enough 10A and therefore can't make enough clot. So we generally find that the chromogenic assay does reflect the bleeding phenotype better than your one-stage assay because of this population of patients that have that particular mutation. Because I guess in haemophilia A, it's quite satisfying in that the amount of factor VIII you have is still the way in which we classify how severe you are. And your bleeding phenotype generally does follow how much factor VIII level you have, how much activity you have. It's like quite proportional to it. And so you just want a clotting test which will accurately measure your factor VIII level because that will be really useful clinically in knowing what you expect from your patient. The reverse discrepancy is the other way round, and that's basically where your two-stage makes your factor VIII come back higher than your one-stage assay. And that's the opposite. So basically that's where you've got mutations in factor VIII that affect binding to factor IX, so that it takes longer to bind, and therefore the incubation in the chromogenic or two-stage assay actually means that you overestimate how much factor VIII activity you've got. This is less clinically significant, though, if you have a mutation that affects how long it takes to bind, because you're still going to make enough clot. It just takes a bit longer to get there. So that's why, generally, bleeding phenotype in patients with haemophilia A does correlate better with the two-stage or the chromogenic assay compared to the one-stage clotting assay.
Yeah, you'd rather have too much than too little.
Yeah, I hope I haven't completely blown your brain with that last bit, but I think that's useful also in thinking about the difference between the two types of assay and why we do both. And
it totally feels like an FRCP question, doesn't it? Where you're like,
yeah,
oh,
exactly.
what's going on here? And you're like, oh dear.
Yeah, exactly. Because you've got to go back to thinking, okay, how do we actually run the assay? Okay, well, the one-stage assay, you don't have any incubation period, and the two-stage you do. So if you've got a mutation that means your factor VIII binds and then drops off, which is going to be an issue in real life, then that's going to mean your one-stage assay is only getting really a snapshot, I guess is the thing. It's getting a snapshot in time. It's not getting the full kind of picture as time goes on. So, yeah.
Nice.
So I think maybe we should go back to our clinical cases where we started and just apply this quite I don't think heavy is the right word because I find this stuff really interesting, really satisfying. But
I'll call it heavy. I'll do it for the I'll do it for the team. Yeah.
But yeah, maybe we should just just finish with some cases to just see if we understand what we've learnt. So going back to our 13-year-old male, he had the APTT of 60, right? And then we took a history and everything. There wasn't much, and then but he hadn't had. We agreed that he hadn't had much in the way of hemostatic challenges, and then we did what next, David? What would we do next?
So we've done our APT and PT. He's got a prolonged isolated APTT. So we're going to do a mixing study.
Lovely. So on mixing, it corrects to 30 seconds.
So we're then going to do a factor study.
What I'm going to pull you up on is you've just assumed that the incubation also corrected on mixing.
Yeah, that's
Because
how I fail.
because if it corrected, I said it corrected, but I very nastily didn't tell you if it
Yeah,
corrected on initial
sneaky.
mixing or on incubation. So you need to ask, is it on incubation that it also corrects? And the answer is yes, David.
Oh, fantastic.
Yeah, so you
Fantastic.
are still right, and yes,
Yes.
therefore you're completely correct in thinking in this case that we suspect some sort of factor deficiency. So then what test would you go on to do?
So a one-stage APTT based factor assay.
Lovely. Followed by,
Uh, uh, a two-stage factor assay.
yeah,
Hopefully for factor 8. Let's pick a number. He's
yeah,
male. Let's go for that
okay,
one.
yeah, fine. And a chromogenic assay.
And a chromogenic assay.
Yeah. So yeah, one stage and usually a chromogenic or a two stage. They're kind of equivalent. Yeah, great. Okay, that's brilliant. Does that all kind of fit with what you've learnt?
Yes, that
Okay.
that feels like the pathway.
Yeah, good. Okay, let's give you another one then. This time we've got a 20-year-old male. He's admitted with, let's say, upper respiratory tract infection, but there's actually a history of weight loss in the background there. And his APTT is prolonged, let's say at, I don't know, 94.7 seconds. You've taken a history.
Punchy. Yeah. Yeah.
You've taken a history. There was a bit of bleed, like a hematoma in one of the legs. No drugs that are relevant, no drug medications. What are you going to do?
Okay. So got some stuff going on. We've got a prolonged APTT,
Hmm.
and
PT was normal.
isolated.
Yeah, PT was
PT was
normal.
normal.
Mhm.
So I'd like a mixing study,
Okay,
an immediate one, and this time and an incubated one.
lovely.
learned my lesson. Uh,
Oh, I'm cruel.
those two things.
Yeah, okay. So on mixing, an immediate mix, it corrects.
Yeah.
On incubation, fails to correct.
Okay. So this time I'm thinking more an antibody
Okay, lovely.
as opposed to a straight deficiency. And
Yeah.
I guess given that we've got this slight history of respiratory tract infection, we've got the
Hmm.
weight loss,
Hmm.
maybe I'm thinking there's something producing antibodies, maybe something neoplastic going on.
Very good. Yeah, exactly. Yeah. So this is sort of a classic case of an acquired haemophilia A, which we can talk about in a whole separate podcast. Very interesting condition. But yeah, it's usually a paraneoplastic antibody, or at least is something that you should be thinking about. Yeah, very good, David.
Okay, so
Yeah.
yeah, no, yeah, finally got a case correctly. Maybe you could sort of sum up what you do, your brain process when you're phoned up with an anomalous clotting result.
Yeah. Okay, great. So first thing is obviously the history, family history, drug history. And then looking at the PT, is it an isolated rise in the APTT or PT, or is it both? Because then that helps you with your differentials. We've got that nice list of differentials we went through last time for that in the clotting screen first podcast. And then what I think is, okay, is this going to be a factor deficiency, or is there something else that's interfering with my test? So I do a mixing study, and I remember that I need to look at both the immediate mix and I need to look at the incubated mix to make sure that I don't miss antibodies that need a little while to work and to inhibit, because those are clinically relevant in real life. They have the time to inhibit. They're not just a snapshot clotting test in the lab. And then if it corrects, I'm like, okay, fine. That means that with my mixing study, I've replaced factor using the reference plasma in the lab. So I'm going to go on and do factor assays. And if it fails to correct, I'm thinking, okay, this might be an antibody that's relevant or not relevant clinically. So it could be a lupus anticoagulant, which may not be relevant, particularly if the bleeding history is the issue rather than clots. Or it might be an antibody against 8 or 9, either acquired or an autoantibody. So either an allo or an autoantibody, both are going to be acquired. Sorry, you're not born with an antibody against your factor. And then also think about drugs. And if things don't make sense, think about drugs and go back to pre-analytical variables. Don't forget, could this sample be contaminated with heparin, etc. And then in terms of your factor assays, I then would do a one-stage clotting assay first, and then I would then go on to do a chromogenic assay to confirm. Maybe not in everybody, but certainly in any borderline results or anyone where I was particularly worried or there was a significant bleeding history, I'd be going on to do a chromogenic assay, particularly bearing in mind that some patients with mild haemophilia A in particular can be missed. I think it's 10%, we said, by doing just a one-stage clotting assay. And that would be my thought process.
Lovely.
Great. So
hopefully that means we don't have to call you so often.
Yeah, and also hopefully it just means that it's starting to all slot together more and you realise that clotting isn't as hard as you think it might be. And that if you have a logical flow chart of what you do next in your head, that can really help you to understand what you're doing and why and how to interpret it. It's wonderfully logical. So next time we will do a bit of a miscellaneous podcast on some of the remaining practical hemostasis tests that we do. So in particular things like the thrombin time and all of that. And we're also going to do a series that's separate podcast on inhibitors, and we're going to do a separate one on different assays that we do in the lab to monitor the effect of anticoagulants in patients.
Great.
Fantastic. Great. Well, thank you, David. I'm sorry that that's dragged on a bit from my point of view. But thank you for bearing with me. And
pleasure. Thank you, Harry.
Yeah, I'll see you soon.
Cheers.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.